Hello, I'm Adrian Gowdy, and in this lecture we're going to talk about using ultrasound to evaluate joint effusions and to guide aspirations and injections. So why do we bother using ultrasound? Well, sometimes we actually don't need to. If there's a very prominent effusion that we can find clinically, if the anatomical landmarks are very clear, then we may well not need to use ultrasound. This is how we've been doing joint aspirations and injections for a long while. But sometimes it's not always that easy. Sometimes the clinical assessment of effusions can be very difficult. Aspiration by anatomical landmarks can also be difficult sometimes, and certainly anyone who's tried repeatedly to aspirate an effusion that they are sure is there and not managed to get any fluid can testify to this. One of the things you may notice if you're using ultrasound to guide injections is just how far off you would have been had you only used anatomical landmarks, in particular if your intended target is quite small. So what are some of the general principles of joint ultrasound? Well, first of all, I'd say look for the effusion where you normally would clinically, because that's where it usually will be. Don't press too hard with the transducer, because in particular in large joints, you may squeeze the fluid out of the field of view that you're looking and into another compartment. Instead, try and milk the fluid towards the transducer and into the area that you're actually examining. So for example, if you're looking for a knee effusion, put some pressure on the suprapatellar region when you're looking in the medial and lateral joint spaces. Now, if you don't find any fluid where you think there is an effusion, then have a look around for other causes. And that would include things like tissue edema. Have a look at the adjacent joints. For example, if you look in the ankle and then can't find anything, have a look in the subtalar joints and the other joints in the midfoot and hindfoot. Have a look at the synovium, looking for synovitis, and look at the tendons for tendonitis. Now, some of these will take a little bit more practice, but as you start looking around joints, you'll start becoming familiar with some of the surrounding structures, and we'll demonstrate some of these to you during the course. So now let's get on and discuss some of the specific joints that we might commonly want to look at. And we're going to talk about the knee joint, the ankle joint, the shoulder joint, and the hip joint in the paediatric patient. So first of all, the knee joint. As we know, fluid will tend to collect in the suprapatellar pouch and at the medial and lateral joint margins. And this is, as we would expect, where we look for fluid clinically. The suprapatellar pouch sits behind the quadriceps tendon, above the patella. And so that's the first place we tend to look for fluid. When we look at the medial and lateral joint line, put some pressure on the suprapatellar pouch to try and force any fluid into the knee joint where we will see it at the joint margins. If we're going to do an aspiration, then have a look, find where the deepest collection is, the one that's going to be easiest to reach, and that's where you can plan to do your aspiration. Now, normally for a knee joint aspirate, I would normally mark the site and then do my aspirate. I don't normally do it watching the needle go in. So in other words, I use an indirect or marking technique rather than a direct visual technique. Here's some diagrams of where we will look for the fluid. Here we can see this is the outline of the patella, so we'll put the probe in a longitudinal plane, usually so we can just see the edge of the patella, and so the probe then sits up on the distal thigh, and we will look through the quadriceps tendon into that suprapatellar pouch to see if there's some fluid there. This is supposed to represent the side of the leg, and we'll look at the joint margin. We do that both medially and laterally, and we'll have a look at what that looks like on ultrasound. So here is the longitudinal view of the suprapatellar pouch. Here we can see the patella. Here we can see the quadriceps tendon. There's always a little bit of fatty tissue here, and here is a tiny amount of fluid in the suprapatellar pouch. This is a normal knee, and in an effusion, this fluid will become much, much greater. But that's the black, usually anechoic fluid that we'll see from in the joint. When we look at the medial side, we again have our probe orientated in a longitudinal fashion. I start high up and then I slide down until I find the distal end of the femur, which we can see here. So this will be the medial femoral condyle. Slide down a little bit further until we pick up the tibial plateau. And in between the two, this is the joint line. And so if there is an effusion, we'll see fluid bulging out from here. Occasionally you can also make out the triangular structure of the meniscus, although it's a little hard to see on this image. On the lateral side, we do a similar thing. Slide down the femur until we see the lateral femoral condyle, which we see coming in here. And here is the head of the fibula. And so this is the joint margin, and this is where I'm going to look for fluid. When I've done that, I'll then decide where is my largest fluid collection, mark the spot, do an aseptic preparation, and then put my needle into that spot and try and aspirate. So, an example from a patient I saw a few months ago. This was a man who was on warfarin. He said to me that he'd had a previous haemarthrosis as a complication of his warfarin, and it had been drained. And he came in because he said the same thing had happened, and could we drain it again, please? But in this patient, when we had a look in the longitudinal view, we see here is the patella. And here, over the top of the patella, is this large heterogeneous fluid collection. This is blood clot. This is the proximal end, this is the distal end of his leg, to help you with your orientation. And once we saw this, we realised that fluid in the knee joint does not spread up over the top of the patella. His whole leg was very swollen, and so it was quite hard to distinguish clinically. We then did go on to look at his joints, and here we have the medial joint margin, and as that loop plays, you can see a little bit of a bulge coming through as we press in the suprapatellar region. And so that told us, yes, there was a small amount of fluid in his joint, but that wasn't the main cause of his swelling, and aspirating his knee joint was not going to give him the relief that he wished. And so we declined, and he was managed conservatively. Moving on to the ankle. In order to image this, we place the probe in a longitudinal plane, and I place it over the distal tibia, and I track it down over the anterior ankle until I find the end of the tibia and the top of the talar dome. And it's in that recess between that we will normally find fluid. If I'm going to perform an aspiration, I'll look for where the deepest pocket of fluid is, remembering that there's tendons that run down in that area, and there's also the dorsalis pedis artery, and so I'll try and look for where those are to make sure that I don't put my needle through those trying to get the fluid. If I don't find any fluid, then I'll go a little bit further down and I'll look for fluid in the other joints that can mimic an ankle effusion. So here's an image that shows the position of the probe, and when we do that, this is what we'll see. Here is the distal tibia coming down here. Here is the dome of the talus, and so this is the area I'm going to look for fluid. And if I see black fluid bulging out here, then I know that I've got an ankle effusion. Now here's an example from a man who came in with a swollen ankle, and we thought he had an ankle effusion. But when we looked, the fluid wasn't actually in that joint. The fluid was a little bit further down and was actually in the talonavicular joint. And what we've done here is we can see some bone here, we see some black fluid, and when I play the clip here, we can see a pulsating vessel. So we have the probe here orientated obliquely to try and give us a line of approach that we can watch the needle come in that was going to avoid all of those. And if we look at the right hand side of the image, just around here, you can actually see the local anaesthetic injection being performed. And this is the aspirating needle. We put the local anaesthetic in. We come in along that plane. We're avoiding the vessel that we saw over here. We watch the needle go into that fluid collection, and we can aspirate a sample, which we then sent off to microbiology. The shoulder joint is, again, one of the most commonly ultrasounded joints, not just for injections, but also for looking for rotator cuff pathology. Now, one of the things we have to remember here is that we're just looking for effusions. We're not going to talk to you about how to do a full shoulder examination because that takes quite a lot of time and practice. It's important to remember that the glenohumeral joint communicates with the proximal biceps tendon sheath, and that's very, very fortunate for us because this is one of the things that it's very easy to examine. And so often this is where we will first of all look for fluid, and if we want a sample of that fluid, it's often easier to take it from around the biceps tendon rather than trying to get a needle into the joint itself. So that's all anterior, but we then also look posterior, and we look at the glenohumeral joint at the posterior labrum, but we have to remember that's a deeper structure and it's usually a little bit harder to image. So here are some diagrams to show the probe orientation. Anteriorly, we transverse, and what we do is we start off a little bit distally, pick up the humerus, slide up the humerus until we see the bicipital groove, and then we look for the biceps tendon in that groove. We then will turn the patient around and posteriorly, again with the transducer orientated in a transverse orientation, we then will look for the posterior labrum. So this is what the biceps tendon looks like in transverse, and as well as this we will turn the probe around and look at it along the line, a longitudinal view of the biceps tendon. Here we have the round tendon here, and here we have the greater and lesser humeral tuberosity with the bicipital groove in between. Posteriorly, the glenoid labrum tends to be a little bit deeper, and especially in large people it can be a bit hard to find, but we have here the humeral head coming around, and that's usually quite easy to identify because you can ask the patient to just move it slightly back and forth to help you identify it. And here we have the outline of the glenoid labrum. And so posteriorly fluid will tend to collect in this area between the two here. Now I'm also going to mention and talk about the subacromial bursa, because this is something that you will see if you start looking at shoulders, and it's also one of the most commonly injected sites under ultrasound guidance. Now, a couple of things to remember. The subacromial bursa lies between the deltoid muscle and the rotator cuff muscles. Normally, it does not communicate with the glenohumeral joint. However, if you have a complete tear of your rotator cuff muscle, then it will communicate. And in that case, you can take fluid from the subacromial bursa to sample for the glenohumeral joint. And remember that an injection into a subacromial bursa, if there is a complete tear, is an intra-articular injection. So for this, we have our probe orientated in a coronal plane, running usually just across the top of the shoulder, just before the curve of the shoulder begins. And when we do that, what we see is skin subcutaneous tissue, then the deltoid muscle, and then the rotator cuff muscle, and finally the humerus, and this is the greater tuberosity here with the rotator cuff muscles coming and attaching. And between the rotator cuff and the deltoid is this space here, which is the subacromial bursa. And if we're going to do an injection, we keep our probe in this position and bring our needle in here along this orientation till it just comes into the subacromial bursa. You know you're in the right place when you're injecting because the bursa itself is quite large, so as you inject you'll see the fluid all run off distally. If the fluid's all collecting around where you're injecting, you're not actually in the bursa. but trying to inject into a very small bursa can be quite difficult. So this is what it looks like. This is a slightly more oblique orientation, but this is what it looks like in a patient who's got a lot of fluid in their subacromial bursa. Again, we have the skin, subcutaneous tissue, we have the deltoid muscle. The other side, we have the humerus, the bright echogenic surface of the bone. We have the rotator cuff. There's often a little black space in here, and that is the cartilaginous covering of the humeral head. And between the rotator cuff and the deltoid muscle is the subacromial bursa, in this case distended with a large fluid collection. Now this is an example of a patient who had a spontaneous haemarthrosis. He came in with a very painful swollen shoulder, very limited movement. He was an elderly gentleman, and it's not uncommon for these patients to have complete rotator cuff tears, and sometimes you can struggle to find any rotator cuff at all, even though they don't have any particular history of injury. And so here what we see is the humeral head. We see the skin, subcutaneous tissue and deltoid muscle, but we don't actually see any muscle of the rotator cuff, and that's because in this patient it's all completely torn and is non-existent at this point. But between, instead, we had this fluid collection, which with pressure we could see actually moved around a little bit, and it was sedimentation of the blood cells in there that was causing this grey pattern. And we'll see that in the next slide. This is a loop. Here we can see this is the needle we've passed in and we've started aspirating, and when I play the loop what you'll see is the red cells actually being aspirated back up, and this is some of the more clear fluid. And we can actually see the sedimented and sludging blood starting to swirl around as it gets aspirated up the needle. We aspirated quite a large volume off there, relieved a lot of the pressure, and symptomatically made a great improvement to this gentleman. So the final joint I'm going to talk about in this lecture is the hip joint, and with particular reference to the paediatric patient. And this is often done as part of the workup of a child who has a limp or who will not weight bear on one limb. Now, one of the things you've got to remember is that both irritable hip and septic arthritis can cause an effusion. So seeing an effusion doesn't always help you that much in terms of making your final diagnosis. And so you still have to put this information in the clinical context and other investigations such as CRP and white cell count. And if it's still unclear, then you may need to take a sample for microbiology. But the converse, that if you have a patient who has no fluid in their hip, well, that makes it very unlikely to be septic arthritis. Now, a small word of caution, early on, the amount of fluid in septic arthritis can be quite small. It's uncommon. Most patients you see with septic arthritis have a large effusion and it's very obvious. But very, very rarely, especially if it's rapid onset and early in the course, you'll see a patient who is febrile, very painful joint, won't move it, there won't be much fluid in there, but it might still be very early septic arthritis. So, as with all ultrasound, you have to put this information into the correct clinical context to get the right answer. The idea is we want the probe orientated along the line of the femoral neck. So we have the probe orientated up around the groin crease, aiming almost straight down the leg, but just slightly laterally or slightly obliquely. And then this is what we aim to see. Now, this is a patient who does have an effusion, but we see the femoral head here, and we see the growth plate because it's a child. And here we see the femoral neck, and this is the thing we actually want to look at, because hip joint effusions will tend to cause fluid that collect at the front of the femoral neck. And in this patient, we can see this is the joint capsule here, it's bulging out forward, and there's quite a large effusion here. This is the iliopsoas muscle here. And if we look here, this is the same patient, this is the right hip, which is the symptomatic side. And for comparison, this is the normal left side of the hip. Here we have the femoral head, here we have the femoral neck. And here we can see there's no bulging in that capsule, it's concave here, and we can do measurements. We actually measure from the iliopsoas to the femoral neck, and that's meant to be less than 5 millimeters. And what I think is probably more useful, compare the two sides. If there's more than 2 millimeters difference, then there is an effusion present. But normally it's pretty straightforward. You can see it even without any measurements. Here there's an obvious fluid collection, and here there isn't. Depending on your settings though, the synovium here can appear quite dark or even black, so it's worth looking for that bulging, I think, and comparing the two sides. So these are the measurements that we've just mentioned for the paediatric hip. So in conclusion, ultrasound can assist us in confirming the presence of an effusion or to exclude it, saving us unsuccessful attempts at aspiration. If there is an effusion, it can help locate the largest pocket of fluid so that you can maximise your chance of a successful aspiration. And when you do that, depending on the joint, depending on the circumstances, you might do that either by just marking the point and then putting the needle in without direct vision of from the ultrasound machine, or you may do it by actually watching your needle go into that pocket. And we'll discuss the benefits and disadvantages of each of those methods during the course. We'll also show you some of the other joints, a lot of the smaller joints around the body, so you can get used to looking at the different joints that you may find useful to evaluate with ultrasound. Thank you.